whenever we come across an eyelid malpositioning patient, whenever it is basically an unsightly condition, and on the other hand, it can have the other possible consequences as well, leading to the visual problems and as well as leading to the ocular problems. So one should know how to diagnose these cases of eyelid malpositioning. Looking at an eyelid would give you the detail regarding the malpositioning in a particular patient. You should know the normal anatomical positions of both the palpebral fissures and both of the eyelids as well. The scleral show, on the other hand, is another diagnostic factor which is very helpful whenever you are diagnosing the cases of eyelid malpositioning, which we'll be discussing subsequently in this lecture. So first of all, we have the eyelid malpositioning phenomena as the most common causes of the eyelid malpositioning, and the categories of the eyelid malpositioning that will be discussed over here are the ptosis, which is basically defined as the drooping of the eyelid. As you can basically see, how can you basically diagnose a person to be suffering from drooping of an eyelid or the ptosis phenomena? You have to evaluate it with the normal eye. This is the comparison with the normal eye that is very significant over here. So this comparison again is very important. So this ptosis phenomena will be discussed over here, and you should know how there are basically the different varieties of the ptosis out there which we can have. The causative factors categorize this ptosis phenomena into the different formations. It can be the myogenic ptosis, we can have the neurogenic ptosis, and the first and the foremostly, it can be the congenital ptosis, which is the most common cause of the ptosis in a lot of cases. Then we'll be briefly discussing dermatochalasis. The definition of dermatochalasis is basically an extra skin tag that is basically causing the drooping of the eyelid, or that is basically hindering the vision in a particular person. So that is basically defined as the dermatochalasis phenomena whenever we are diagnosing it. On the other hand, we have the upper eyelid retraction. As you can see in this patient as well, that there is a lot of a scleral show. That is basically the diagnostic factor whenever we say there is an upper eyelid retraction in a particular case. Obviously, there are multiple causative factors towards the development or towards this scleral show that is quite visible over here. And whenever we compare it with a normal eye, we can clearly distinguish that this person is suffering from the upper eyelid retraction in this particular case. The causative factors basically range from the thyroid eye diseases. Whenever you are taking the history from this particular patient, you have to have the past medical history as well as the past surgical histories, because in a lot of cases, patients who have undergone ocular surgeries usually present in such situations of the upper eyelid retraction, as we can see over here. So this particular history taking is again very important, and one should know how to take the history in detail. The family history is again very important, because a lot of autoimmune disorders, for example, it can be the myasthenia gravis, which is one of the kind, and it basically causes a lot of factors and a lot of malpositioning factors. Whenever we have a patient of ptosis, for example, it can be due to this autoimmune disorder, which is myasthenia gravis. So taking the history whenever you have these patients of eyelid malpositioning is again very critical in this scenario, or whenever a patient walks into your clinic and you diagnose this patient to be suffering from the eyelid malpositioning, you should know that the patient particulars as well as the presenting complaints, the history of presenting complaints, the chronicity of the problem, how long this problem has been prevailing, whether it is a unilateral condition or whether it is a condition which is affecting the bilateral, or it is affecting both of the eyes, and the severity of the condition. That is again very important. So these are the particular points or the highlighters that you have to keep in your mind whenever you have a patient of eyelid malpositioning in your clinic. And once you are done with this initial history taking phenomena, you will start off with the clinical examination, and all of these signs that are quite clear over here and that are basically giving you an overview regarding the different malpositioning phenomena you have to look for in this particular patient. So if we go into the details of ptosis, as I've already told you, there are different multiple kinds of ptosis out there. It's depending upon the causative factors how you classify ptosis. You have this aponeurotic ptosis. So it's basically the problem that is relating to the aponeurosis of the orbicularis oris, that is basically resulting in the drooping of the eyelid. So the laxity of the aponeurosis of the orbicularis oris is basically going to result in the ptosis phenomena in this particular individual. As you can see, it is clearly manifested over here that the left eye in this patient is basically showing the drooping in this particular patient. So you can compare this, you have the normal eye for comparison. So that is again very important. Usually it's a unilateral condition, and whenever it is a unilateral condition, you should know that it is a case of trauma, most probably. It is a case of previous ocular surgery that damaged the facial nerve, and that is resulting in this particular kind of ptosis phenomena. On the other hand, it can be the myogenic ptosis. The myogenic ptosis is again caused due to the damage to the nerve supply of the orbicularis oris or the levator muscles that are responsible for the retraction of the eyelid, and if they're not working or functioning in a proper manner, they're going to result in this drooping of the eyelid as seen in this patient over here. Then we have the other autoimmune disorders, for example, myasthenia gravis, and that is again one of the problems that is occurring at the neuromuscular junction over there. So these particular acetylcholine are not released at the neuromuscular junction, and that is going to further result in this drooping of the eyelid. The functionality, the overall functionality of the muscle is going to be affected in this particular case. And we see that we get along these patients to be suffering from this drooping of the eyelid. Now, why is it important to treat these patients, and what are these particular surgeries that are performed for these particular patients? That will be discussed. But first of all, one should know what are the aims and objectives towards these treatment phenomena that we have. Obviously, whenever you have this drooping of the eyelid, if it is a congenital kind of ptosis as seen in the children, the child might suffer from amblyopia later on, and that is again a condition which is going to affect the vision of this particular child. So one should know how to treat these ptosis situation and how to get along with these patients and how to manage these patients in the correct way. As you can see, it can be a unilateral condition, as I've shown you in another patient, and over here you can see that we have a patient in which we have this condition affecting both of the eyes, or it is a bilateral condition. As you can see over here, the scleral show is affected, and it's almost covering half of the lids, and that is basically the severity is again very important. Whenever you have this patient, you're going to assess whether this condition is a unilateral condition or whether it is a bilateral condition that the patient is suffering from. Then you have to assess what kind of the severity the patient is suffering from, whether it is a case of a mild, moderate, or a severe kind of ptosis. Why is this important? Because the final outcomes and the prognostic factors after the treatments or after the surgeries have been performed, that again depends upon the initial presenting status of the patient. So this is again very important when you look at the patient and you're assessing the patient. You need no special instruments to assess these patients or to clinically examine these patients. Rather, you just need a well-lit room and you'll be inspecting the patients in detail. On downward gaze, you're going to see whether this drooping of the eyelid is worsened or not. This is again a very important factor whenever you're distinguishing a case of a myogenic ptosis from an aponeurotic ptosis, because if it is a case of aponeurotic ptosis, on a downward gaze, the drooping of the eyelids would be worsened. So this is one of the distinguishing factors that you have to evaluate in these patients. The correction of ptosis is very important. The aims and objectives are to basically have the vision improved, have the clarity of the vision improved in the patient. And there are a lot of surgeries that are performed depending upon the causative factor. You have to obviously treat the underlying cause in these particular patients, and you'll be basically first of all investigating what is the underlying cause in this particular patient. So there are these particular tests to evaluate whether it is the myasthenia gravis, whether it was a congenital malformation, or whether it is an aponeurotic, or where either it is a myogenic kind of ptosis. And once you have evaluated the patient and you see that this is some sort of an aponeurotic kind of a ptosis in this particular patient, so you're going to basically perform the surgery to correct the levator muscles in this particular patient. As you can see, we're going to cut open, we're going to give incisions over here, and you're going to perform the corrective surgeries in these particular patients. These are the levator muscles that are pointed out over here on this slide. We give out the skin incisions, and then you perform the aponeurotic, or then you perform the corrective surgeries in these patients of the ptosis. And finally, the final outcomes or the final prognostic factors in these patients are quite good if these surgeries are performed in the less severe cases, or if it is a case of a unilateral condition of ptosis. So whenever we are discussing this eyelid malpositioning, one of the phenomena which we commonly come across is dermatochalasis. So usually dermatochalasis is the excessive skin fold that is attached to the upper eyelid. Usually the upper eyelid is the most affected eyelid whenever we are discussing this case of dermatochalasis. Usually, again, you will come across that this dermatochalasis is usually a congenital kind of a condition or a by-birth condition, and in a lot of cases you see a senile kind of a dermatochalasis whenever there is a laxity of a skin observed in the advanced ages. It is sometimes associated with the dermatochalasis phenomena. As you can see, this is a senile patient. This is a patient of an advanced age or old age. You can see over here there is an excessive skin fold that is covering the eye. So this eyelid is basically not drooping. So you have to basically distinguish this phenomena from the drooping of the eyelid. It's not the drooping of the eyelid, it is this excessive baggy eyes. On the other hand, a layman terminology which is known as the baggy eyes phenomena is used for this condition of dermatochalasis. Again, the outcomes would be similar, quite similar to the ptosis phenomena. The vision, the ocular complications can be seen in these patients. So sometimes it is just not an unsightly condition that you have to treat. You also have to treat these patients due to the ocular or the visual abnormalities that they're facing. So again, it's very important to have a look at this. The laxity of the skin is one of the factors that you can see over there. On the other hand, we have the other connective tissue problems that are sometimes causing this bagginess of the eyes and the swelling of the eyelids, quite prominent or quite excessive in these patients over here. So you can see that we have the other conditions. For example, we have the upper eyelid retraction, which is another phenomena. So it's usually when you have these patients of eyelid malpositioning, we categorize these patients into the drooping phenomena. On the other hand, the retraction phenomena. We have the upper eyelid cases, we have the lower eyelid cases. We are focusing over here on the upper eyelid retraction. Again, it is a very important sign or a clinical feature that we observe in patients. There are a number of factors that can result in this upper eyelid retraction. We can have the thyroid eye diseases first and foremostly, the patients are going to present as the upper eyelid retraction in these cases. On the other hand, we can have people who have suffered from recent trauma. So you can basically list these cases as such. First and foremostly, the TED, that is basically the thyroid eye diseases. Then we have the traumatic cases. Thirdly, we have the infectious causes or the chronic infections, which can again relate to these upper eyelid retractions in these cases. So as you can see, how can a chronic inflammation, it's again termed as CPEC, this is an abbreviation used for the chronic progressive external ophthalmoplegia, and again it can present as this eyelid retraction cases, as you can see over here in this patient. So how will you diagnose these cases of whether this upper eyelid retraction, this scleral show is very important. Just focus over here. You can see that this is an abnormal scleral show that is seen over here, and that is going to be the highlight whenever you are diagnosing patients to be suffering from the upper eyelid retractions in these cases. And you can even compare this affected eye with the normal eye. Over here you can see there is no scleral show. The absence of the scleral show means that it's a normal eye. And on the other hand, you have a comparison of the upper eyelid retraction, just to give you a better understanding of this condition. So again, what can be the complications that are related to this? Either it is an upper eyelid retraction, or it can even be the lower eyelid malpositioning or the retractive cases in this phenomena. The complications would obviously be of the, it can be the corneal ulcerations or the dry eye syndrome that is mostly associated with these retractive cases or this malpositioning cases that we usually come across. There is an excessive hindrance of this lubricating phenomena that is occurring in the eye, and that is going to result in the dry eye syndromes in these patients. So usually you'd start off with the milder treatments, which are basically focusing on the fact that you're just treating, for example, you're going to prescribe the natural tears in these patients just to have a better lubricant phenomena that is associated with the eyes. And then, of course, you're going to treat the underlying cause in these cases as well. So once you're done with the upper eyelid, you have the retractive causes, and on the other hand, you have the drooping eyelid phenomena. We're going to move on to the lower eyelid. Even the lower eyelid is affected in a lot of cases in which there is the malpositioning phenomena that are associated or that are sometimes looked upon whenever we have these lower eyelid malpositioning phenomena seen. Entropion is basically one of the conditions in which there is an inversion of the lower eyelid. So whenever you have these patients of entropion at your hand, there is an inversion of the lower eyelid. The complications would be suggestive of the patient would be giving you a history of a foreign body sensation, and that is again due to the lashes that come in direct contact with the conjunctiva and the sclera. So that is the main complications that is going to occur. Again, there is going to be an irritative phenomena that is observed by these patients. So the clinical signs and symptoms and the diagnosis again is made by a well-lit, just a torch examination or a slit lamp examination can be very helpful whenever you are diagnosing these cases of entropion. So this is a case which is suggestive. As you can see, there are inflammatory changes even observed in the lower eyelid. And again, there is an inversion of the lower eyelid. The eyelashes are coming in direct contact with the conjunctiva and the sclera, and that is going to give you a foreign body sensation in these patients. Then we have the ectropion. So ectropion is can be defined as the eversion of the eyelid. Again, we're talking about the lower lid. As you can see over here, we have these patients in which we have the lower eyelid eversion. This again has its own complications. It is going to be quite a phenomena in which the palpebral fissure is not closed properly even after closing of the eye, and that is again going to result in the dry eye syndrome, or it can be the corneal ulcerations that can occur in these patients. So these are some of the complications that are correlated with the ectropion over here. Then we have the lower eyelid retraction that is sometimes associated with, as you can see, most of these cases which are affecting the lower eyelid, the causative factor behind them can be, on one hand, it can be the age factor. Usually these conditions are senile in most of the cases. In advanced ages, you usually come across the senile entropion. We have cases of senile ectropion. We have cases of senile lower eyelid retraction. So usually it is a case in which we have the fibrosis that is associated with the advanced age. So it is a senile condition mostly. Again, it is exposing the eyes, it is exposing the conjunctiva, resulting in the corneal ulcerations. And then finally, we have the facial nerve palsies. So as you can see, whenever we have the facial nerve palsies, it can result in the drooping of the eyelids in these cases. And it can be a lot of factors that result in the facial nerve palsies. It can be the surgeries, the traumas, infections. All of these causative factors can result in a facial nerve palsy, and you have to investigate the case just to get to know the causative factor in this particular case of the facial nerve palsy. So collectively, if we have a look at this lower eyelid malposition, you would get to know that it is usually a senile factor. That is the most prominent factor over here. Then trauma can be one of the cause, or either it can be the infectious causes that result in the lower eyelid retraction over here. So we have this involutional or senile entropion that we usually come across in the old age. The involutional entropion can be due to the fibrosis that is again occurring due to the abnormalities that are occurring at the aponeurotic level. So that will be termed as an involutional entropion. Usually when we come across this involutional kind of an entropion, it is usually due to the advanced aging phenomena in an individual. So what is happening? What is the underlying pathology of this involutional, or in other words, we can see the senile entropion? It is usually the fibrosis or the chronic inflammatory changes that are taking place at the backhand, and that is causing the shortening or the fibrosis of the aponeurosis. And again, this phenomena in which we have the shortening of the aponeurosis is going to result in this particular case of entropion in the advanced aging of the individuals. You can see over here that when we focus at the lower eyelid, there is this inversion phenomena that is noticed in the lower eyelid. Once the lower eyelid is inverted, it is causing a backlash of this lashes towards that comes in direct contact with the conjunctiva or the sclera. So this is the basic outcome that is going to be affected, and that is going to produce all of these signs and symptoms and the clinical features in these particular cases. As you can see, once these lashes come in direct contact with the conjunctiva, they are going to cause the foreign body sensations in these individuals. Even after these sensations, or when this condition is worsened, it is going to cause all of the irritative, the inflammatory changes that are going to start taking place at the cornea. Corneal ulcerations can result, keratitis can result, conjunctivitis can result. So all of these are basically the complications that can be related to this senile or this advanced aging phenomena that is related to the inversion of the eyelids. So treating this involutional or the senile entropion is again very important. The aims and objectives are to improve the quality of life in these individuals. Even after the advanced age phenomena, the quality of life can be improved to after you have performed these surgeries to correct the senile entropion, or to perform the corrective surgeries for the involutional kind of entropion in these patients. So usually the incisions are given, and that is going to you basically cut off these flaps and perform the corrective surgeries at the aponeurosis. So the approximation of the two ends is again very important. You approximate the two ends, and the fibrosis is basically going to be laxed, and this laxity is basically going to result in the normal positioning of the lower eyelid in these patients of senile entropion. So this is another way in which you can see that the cut or the incisions are given in this manner. This is the direction of the incisions or the direction of the cutting phenomena, and then you perform a two-layered reconstructive surgeries to get the better cosmetic outcomes in these patients. Then you have the involutional ectropion in the advanced ages. So sometimes this ectropion is another condition in which we have the laxity that is provided to the aponeurosis, and that is again going to result in this particular kind of an eversion of the lower eyelid. Now, what basically happens is whenever you have these patients of involutional ectropion at your hand, even after the closure of, even after you completely attempt to close the palpebral fissure, again, these patients can suffer from corneal ulcerations in this particular case. Again, you have to perform, or you have to treat, you have to give out the reconstructive surgeries for these patients. To let these patients and to prohibit or prevent these conditions of conjunctivitis and keratitis in these patients of involutional ectropion in the advanced stages. So again, whenever you have these patients who are suffering from the laxity of the aponeurosis rather than the fibrosis of the aponeurosis, so it can be basically both of these extremities. Both of them can happen at the old age. Either it can be the laxity, which is going to result in the ectropion, or either it can be the fibrosis of the aponeurosis, and that is going to result in an entropion, or the inversion of the lower eyelid. Over here, when you are going to treat these patients who are suffering from the laxity and they're going to result in the ectropion in these patients, you're going to perform the approximation surgeries to treat this laxity in these individuals. As you can see over here, you're going to freshen up the ends on both sides, and these surgeries are going to be performed in a two-layered phenomena: the deep fascia, the muscular layer, the skin tags. These are the three-layered surgeries that you're going to perform just to get a better cosmetic out view in these patients who have undergone the surgeries, the corrective surgeries for the involutional ectropion. So this is basically a two-step manner, and you're going to perform, or you're going to apply these sutures in a two-layered fashion, and you're going to approximate the two ends to get a better outcome towards the laxity of these aponeurosis. The involutional ectropion, again, you can raise the flaps from the medial canthus. In these patients, you can raise the flaps from the lateral canthus. The lower eyelid margins can be used for raising the flaps. Basically, the outcome is going to be related to treat the laxity of the aponeurosis in these cases. The palpebral fissure, the closure of the palpebral fissure is the final outcome or the final prognostic factor that you have to evaluate in these patients who are suffering from the involutional ectropion. So on the other hand, we have the medial ectropion of the right lower eyelid. In this patient, you can see we have the medial ectropion. So sometimes it's not the whole eyelid margin that is being affected by this ectropion. It is sometimes the medial end, or it can even be the lateral end. But mostly when you have these patients of ectropion, it's the medial end that is mostly affected in these patients who are suffering from a senile kind of ectropion. Now, there are a lot of factors that can be resulting in this ectropion. It can be the nerves, it can be the muscles. On the other hand, it can be the mechanical kind of ectropion as well. Now, what is a mechanical kind of ectropion that you usually come across? It's usually a tumor or a neoplasm that is resulting in this ectropion condition, and that again would depend upon the location of the neoplasm over here. So you have to look for all of the features. You have to completely examine the lid. Look for the signs of inflammation on the lower lid, and look for the signs of any mass that is found on the lower lid and that is causing the retraction or the ectropion in these patients. Then we have the paralytic ectropion. You can see whenever we have this paralytic kind of ectropion, it's usually nerves supplying the levator muscles, the nerves supplying the orbicularis muscle that is affected in these cases. So it's usually the third nerve, that is the facial nerve, third cranial nerve that is supplying the orbicularis oris muscle. And so for the normal functionality of the muscle, it's very important that the nerve supply to the muscle is not hindered. So if there is any paralysis towards the lower eyelid or the upper eyelid muscle, that is again going to result in this ectropion condition or the retraction of the lower eyelid, or that is depending upon the cause in this particular case. Then, as we were already mentioning, we have a lot of cases of mechanical ectropion at our hand. As you can see over here, you have to examine the lower eyelid in detail. If there are any signs of neoplasm, it would depend upon the location of the neoplasm or the location of the mass, that how you evaluate these patients. This is going to be the ectropion, the lower lid is everted in this case, and this is a mechanical kind of ectropion that is seen in the left eye in this particular patient. On the other hand, we have cicatricial kind of an ectropion that we usually come across. So defining this condition in which you have the eversion of the lower eyelid, or even it can be the upper eyelid, and that is associated with the cicatricial phenomena, which basically means the chronic inflammatory changes that are occurring. So this chronic inflammation that is going to result in the ectropion in this particular condition, it can be due to multiple causes. These inflammations can be autoimmune, it can be due to the infectious causes that are taking place on the underlying phenomena. And even after surgeries, people usually come across this kind of cicatricial ectropion kind of surgeries. So you can see that once you're evaluating these patients of cicatricial ectropion, you're going to start off with the complete history taking. You're going to ask for the past ocular surgeries, or either any history of recent trauma that the patient has suffered from. That is going to highlight the causes or the sources of the infection that finally resulted in an ectropion in these conditions. As you can see over here, we have the inflammatory changes, the redness is observed, and that is associated with the eversion of the lid at the medial margin. So this is the condition that is usually associated with the chronic inflammation. Now, what is the pathogenesis behind this cicatricial kind of an ectropion that is seen in these patients? Usually it is the chronic inflammation, and that is going to furthermore result in the shortening of the aponeurosis or the shortening of the posterior lamella, as well as the fibrosis of the orbicularis fascia. So this shortening of the lamella is finally going to result in the cicatricial kind of an ectropion that is observed in these patients. So it's critically important to treat these patients of cicatricial ectropion at your hand. So usually we perform surgeries in these patients. You treat the infections first of all. If it is a case of a chronic progressive inflammation, you're going to treat that with the broad spectrum antibiotics, or you provide it with the steroids, and you basically hinder out the inflammatory processes in these patients. And then you're going to perform the surgery that is particularly focusing on the ectropion that it has caused. So this, you're going to freshen up the margins in this kind of surgeries. And then you're going to perform, basically, you're going to raise the flaps in these patients as well. And then finally, you're going to perform the reconstructive surgeries that are focused upon the laxity of the aponeurosis. The aponeurosis is reconstructed, and the structures which had undergone the fibrosis, they're reconstructed whenever you're performing this step-by-step surgery, focusing on to treat this ectropion in these patients. So you have this cicatricial ectropion. It's another patient who has been suffering from cicatricial kind of an ectropion. It's the whole lid that is usually involved. There is redness, there is swelling. All of these are basically the signs of inflammation that are noted down in these patients who are suffering from this cicatricial kind of an ectropion. On the other hand, we have the lower eyelid retraction that is sometimes quite commonly observed in a lot of patients. Whenever you look at a patient and you find that there is something there is something wrong with the lids or the positioning of the lids, whether it is the upper eyelid or the lower eyelid, the main highlight towards the clinical features is a scleral show. So there is a lower boundaried scleral show that is observed in this patient, and you can see it's basically the lower eyelid retraction that is seen in these patients. There are a lot of factors. It can be the inflammatory changes, it can be the muscular factors, the paralytic factors that are contributing towards this lower eyelid retraction in these cases. The complications would certainly deal with the retractive cases as any other retractive case. Either it is an upper eyelid or a lower eyelid retraction. It's basically exposing the orbit even on the complete closure of the palpebral fissure. So basically the complications would be the corneal ulcerations, the resources for the different infections, for example keratitis or corneal inflammations or conjunctivitis. So you're basically exposing the eye towards the different inflammatory kind of conditions whenever we have these cases of retraction. So to treat these cases, we again perform these reconstructive surgeries to get a better outcome in these patients. Again, it is very important to evaluate the underlying cause for this retractive phenomena that is seen in these individuals. Then we come across the facial nerve palsy. So it's again very important that you look at these patients of the facial nerve palsy, which are usually regarded as Bell's palsy. So the causes of the Bell's palsy are not quite unknown. It's an idiopathic origin of that is associated with the facial nerve palsy. The sign and symptoms would basically include the drooping of the eyelid that is quite commonly associated with this phenomena of the facial nerve palsy, or it's also known as the Bell's palsy. Facial nerve is the seventh cranial nerve. Sometimes it is the seasonal changes that are affecting, or the extreme weather conditions are sometimes related to this facial nerve palsy. So you should know how to correlate these clinical features and diagnose these cases of the facial nerve palsy over here. So whenever you have these patients of facial nerve palsy at your hand, you would see, or you would observe this drooping of the eyelid, or ptosis that is associated with it. And then we have the drooping of the corner of the mouth. Then we have the loss of the nasolabial fold. So these are the particular features that are seen in the facial nerve palsy. So it's basically usually the ipsilateral side that is affected, or the side on which the facial nerve is affected. That would be noted down over here. And on the other hand, you can see that on the contralateral side, there will be a loss of the nasolabial fold that would be associated with this kind of a facial nerve palsy. The treatment that is associated with the facial nerve palsy is the steroids is the mainstay of the treatment. Whenever you are treating these patients of the facial nerve palsy, it would usually be self-contemporary. It will go away by itself, but you have to give the steroidal treatment just to avoid any complications in these cases of the facial nerve palsy. So this is basically one of the condition that again is going to result in the malpositioning of the eyelids that we were talking about. So in this particular lecture, we summarize the different scenarios in which the eyelids can be malpositioned. Obviously, there are these multiple factors out there ranging from the traumas, the infections, and the congenital causes that are usually related to this phenomena of the eyelid malpositioning, whether it is the upper eyelid or either it is the lower eyelid that is affected in these cases. So we have a range of lectures at sqadia.com that are basically focusing on the different ocular or the visual problem diseases, and you should just check out these lectures at our website. Thanks for watching, and to get a complete access to view the complete lecture, you should get the complete access.